Welcome to Grand Rounds. Dr. Roman is out of town, so he asked me to get things started. I have yet to figure out where he gets his information for history, so I won't even try to do that today. But I will introduce the Chief of the Division of Pulmonary Medicine, Dr. Mohammed Saad, who will introduce today's speaker.
Good morning, everyone. This is the first of our pulmonary critical care grand round, and I'm pleased to introduce our speaker today, Dr. Umair Gauhar. Dr. Gauhar did his medical training in Edward King College in Pakistan and came to the U.S. and did his residency and fellowship at University of Alabama. And he stayed on for 2 years before he decided that he wants to do an intervention pulmonology because this is what he wanted to do. So he went to Ohio State for a year, and we were lucky to have him join us after he finished his training. So he joined us in January of 2013 and started our interventional service at VA. So for you who work at the VA, you know that he's doing all the fun stuff over there. And we also we're happy to see him starting our pleural service at university just recently. And the topic today is one of the areas that he likes to talk about, which is the management of malignant pleural effusion from the interventional pulmonology perspective. Dr. Gauhar.
Thank you very much, Dr. Saad and Dr. Casper. So the topic that I've chosen today is malignant pleural effusion. Pleural disease is very interesting and somewhat neglected in research studies as well. So as you can tell from the title of my talk, my challenge is to stay objective while being totally biased. So a little bit about the organ, the tissue that we're going to be talking about, just to get familiar with this part of the body. The pleural surface or the pleural tissue is a derivative of the embryonic mesoderm. And of course, we have the parietal and visceral pleura. They differentiate from each other by the 3rd week of gestation. And then the pleural cavity differentiates from the pericardial cavity in the 9th week of gestation. It is a large surface area, about 2,000 centimeters square in the adult male. And the pleural space is a potential space. As we know, it's about 10 to 20 microns, and generally has a very small amount of fluid, about 10 milliliters. And the two surfaces of the pleura are joined here at the pulmonary ligament. So this is the right chest. You're looking at the right chest from the right side with the lung taken out, and this is the hilum of the lung. And just in the infrahilar portion is the union of the visceral and the parietal pleura in the pulmonary ligament. And of course, the pleura anatomically is divided into the diaphragmatic pleura, the costal pleura, the mediastinal pleura, and the cervical pleura. The blood supply of the two different pleural surfaces comes from two different sources. The visceral pleura derives its blood supply mainly from the pulmonary circulation and a little bit from the bronchial circulation. But regardless, the blood supply of the visceral pleura travels quite a distance to get to the visceral pleura, as opposed to the parietal pleura, which is supplied locally by the intercostal arteries. So this is what the pleura looks like. You've got the lung underneath, and then this is the pleural tissue, very thin. There's a single layer of mesothelial cells resting on the basement membrane. Then you have a small amount of connective tissue with venules and lymphatics. And then you have the superficial and basal deep elastic lamina. So just imagine that if you have lung cancer, all lung cancer has to do to metastasize is cross this one delicate line and enter into the lymphatics and venules, and then you have hematogenous spread. So it's amazing that a lot of lung cancer stays within the lung, even though this is the small boundary that it has to cross. How is the pleural fluid circulated? This is an important diagram for people who study pleural disease and deal with pleural disease. So we know that pleural effusion normally is an ultrafiltrate of the plasma. So this is the lung tissue right here. So it's squeezed through the capillaries, gets into the pulmonary interstitium, then leaks through between the cells of the visceral pleura to enter the pleural space. And then on the parietal pleura, you have these 2 to 6 micron stomas that contract and expand with each breath and essentially suck all the pleural fluid to drain it into the lymphatics. So when we talk about malignant pleural disease, the two main problems are on the visceral pleura. Because of involvement of the visceral pleura, there's increased permeability of the visceral pleura, so there's increased leakage of fluid. But the other problem is usually the lymphatics get clogged up with malignant cells. So this way you have increase in the accumulation of pleural fluid. What does a normal pleural fluid look like? As I said, it's very small in amount. So 0.1 to 0.2 milliliters per kg. So in an average 70 kg man, and when I say average 70 kg man, these days that term sounds like a mythical creature. So it's about 10 to 14 milliliters in an average 70 kg man. It's clear, low protein, and most of the protein is albumin. It's alkaline. Its glucose is equal to plasma, and the LDH is usually less than 50% of the plasma LDH. When we look at the cells of a normal pleural fluid, most of the cells will be of the monocyte macrophage lineage with some lymphocytes and mesothelial cells. What is important to note is that normal pleural fluid does not have any eosinophils and very few neutrophils. When we look at the rate of production of pleural fluid versus the rate of absorption, you can see that there's a tremendous difference between the two rates. So the body's ability to absorb pleural fluid is about 30 times its ability to produce pleural fluid. So anytime you have even a small amount of pleural effusion, that signifies a major discrepancy in this process. So it means that the process of absorption has been overcome, and this is a major dysfunction even if there is a small amount of pleural fluid, because the body's ability to absorb is so high. Normally the function, the absorptive function is almost confined to the parietal pleura. So it's the parietal pleura which is very important in absorption of pleural fluid. Let's change gears and focus on the topic of today, malignant pleural effusions. How is a malignant pleural effusion defined from a pulmonary standpoint? If you find malignant cells in the pleural fluid, either on cytology or immunohistochemistry, you have defined the effusion as a malignant pleural effusion. The incidence is about 150,000 cases annually in the US and about 40,000 in the UK. About 15% of all malignant disease will have some amount of pleural fluid, and most of these will be exudate. But what is important to know is that about 10% of malignant pleural effusions can be transudates. So a transudative pleural effusion does not exclude a malignant pleural effusion. Malignant pleural disease is one of the few causes of a massive pleural effusion. A massive pleural effusion, by definition, is something that can shift your mediastinum. But if you have a massive pleural effusion and you do not see the mediastinum shifted, that means that the mediastinum is either encased with something such as mesothelioma, or there's an endobronchial lesion causing atelectasis of the lung. So there are two opposing forces. In those cases, bronchoscopy becomes important. In general, a malignant pleural disease portends a poor prognosis. The average survival is about 3 to 12 months, but we'll talk about this point in a little bit more detail later on. As far as the causes of malignant pleural disease, I don't think this is a surprise, especially for people who work and live in Kentucky with the smoking rates that we have. This is a collection of several studies. As you can see in the right side column, most of the malignant pleural effusions were related to lung cancer, followed by breast cancer, lymphoma, and gastrointestinal disease. And then about 10% of the malignant pleural disease was of unknown primary, which again is not an uncommon scenario in in our practice. How does cancer involve the pleural tissue? This is an ultrasound, and we'll talk a little bit about the role of ultrasound in pleural disease. So you have these thick adhesions in the pleural space, and what malignant cells can do is involve the visceral pleura and then travel along these strands to involve the parietal pleura. That's one way. Or they can directly grow as a large mass into the pleural space and involve the parietal pleura. Then obviously through the bloodstream and lymphatics is another way for malignant cells to involve the pleural surface. I want to just introduce this term, which is something that's often used by pulmonologists more than others, the paramalignant effusion. So a paramalignant effusion is an infusion that happens in the context of malignancy, but you cannot find malignant cells in pleural disease. In other specialties, this will be considered a malignant effusion, even if you do not find malignant cells and if you have ruled out other causes. But oftentimes in pulmonology, we like to be more nitpicky about these kind of things. So a paramalignant effusion is when you have done a reasonable workup with thoracentesis, maybe even thoracoscopy, but you have not found malignant cells. And the common causes of a paramalignant effusion in patients with known cancer could be post-obstructive pneumonia, pulmonary embolism, atelectasis or trapped lung, hypoalbuminemia, radiation pleuritis, and effects of chemotherapy. Then constrictive pericarditis, either from radiation therapy or involvement with malignancy by itself, and then SVC syndrome. So just keep this in mind, that sometimes you may read it in our documentation as what is a paramalignant effusion. All right, so I'm going to use this case of a patient that we treated recently to build our discussion and go through different aspects of management of malignant pleural effusion. This was a patient who was referred to us from one of our primary care physicians. She is a 78 years old white female. She came to our clinic because of progressive shortness of breath and abnormal chest imaging. Her symptoms started about 3 weeks ago. She had no fever, chest pain, chills, no weight loss, and she remained active and functional at home. When I saw her in clinic, she was breathing comfortably. Her O2 sats were 95% on room air. On physical examination, she had decreased breath sounds on the right side with dullness to percussion. And her past medical history, other than some other medical problems which are not relevant to our discussion, she did have a mastectomy 8 years ago for breast cancer. And she was being followed at Brown Cancer Center with regular checkups, and in fact had a visit with her oncologist about 4 or 5 months before this presentation and was found to be free of disease. This is her chest x-ray, clearly a large pleural effusion on the right side, and she had a CT scan done by her primary care physician. You can see in this axial slice, she has a large pleural effusion with complete atelectasis of the right lower lobe. So, question for the audience, I think you have your clickers. Given this presentation, what is the most appropriate next step in management? And the time starts now. Large bore chest tube, ultrasound-guided thoracentesis with or without pleural manometry, bronchoscopy, or thoracentesis without ultrasound. That's a huge pleural effusion. Why would you need ultrasound? All right. Okay, so about 60% say that ultrasound should be used, and about 20% think that ultrasound should not be used. This is perfect. Not because 20% are right, because you're making exactly the right mistake. So my plan is working. All right. So the answer is you would use ultrasound. And we will talk about why ultrasound needs to be used, even when the effusion is so huge. So ultrasound or thoracentesis is obviously a very common procedure in pleural disease, and there are very few, if any, absolute contraindications for thoracentesis. Obviously, if there's a very small pleural effusion, less than 10 cc on lateral decubitus, which is usually not done these days because of ultrasound, or if there's an infection in the site, then you wouldn't do ultrasound. As far as coagulation, INR, platelets are concerned, we often get this question from residents, so-and-so's platelet count is 30,000, is it safe? And again, this is a relative contraindication. There is no particular contraindication to not doing ultrasound, but obviously if the INR is very high, twice the limit, or platelet count is very low and the effusion is small, or you don't feel comfortable doing that ultrasound, then clearly you should ask for help or correct the underlying problem. Going through the skin is generally not the issue. It's if you injured the intercostal vessels or the underlying lung in the context of a coagulopathy. So that's usually the problem. In a retrospective study, about 1,000 patients who had thoracentesis guided by ultrasound and had an abnormal INR and platelets, there were no complications. So again, this is not one of those things that you should be terribly worried about. Again, another study of about 1,000 patients, ultrasound-guided thoracentesis with INR more than 1.6 and platelet count less than 50,000 showed very few complications. Even interventional radiologists don't feel like it's a high-risk procedure. So they think that an INR more than 2 or PPT, there's no consensus on it. Plavix is one of those things that we always worry about in pulmonary disease. So if somebody's on Plavix and you're doing an elective thoracentesis, it's a good idea to stop it if you can. But in general, the bottom line is that you don't have to worry too much about INRs, platelets, if you are doing thoracentesis with an ultrasound. We have been told in medical school that the neurovascular bundle runs along the inferior margin of the rib, so always go above the rib. Well, that only holds true on the lateral side. So these are two studies. This one was a CT study. This one was a cadaveric study where they actually looked at the neurovascular bundle. And if you can see on the right side, just imagine that there's the spine that's running like this, and this is the lateral side, so the neurovascular bundle is coming like this from the spine. So they describe 4 different patterns, and if you can see, about 35% were dropping like this in a curve, about 40% were wavy, and then 75% of sinusoidal. So majority of the patients actually fell in this category in the part of the body where we do the thoracentesis. And I don't know if this is showing up well, but this is a CT study, and you can see that the neurovascular bundle is actually pretty far away from the inferior margin. And this is especially true in elderly patients as they lose muscle tone and fat, so the neurovascular bundle can actually drop into the intercostal space. So now then when you do the thoracentesis, you'll be extra careful, and you will be surprised how many times you're able to do a thoracentesis and still not cause a catastrophe. All right, so why is ultrasound needed in thoracentesis? Because it's a very good way to study pleural disease. It's not just taking the fluid out, which is important. It's also looking at the pleural space, because we'll see later on that the appearance of a pleural fluid on ultrasound has prognostic value. So it's not just a way to find the target. It's looking at the pleural space and to determine what the patient is going to do. So it can tell us how much pleural fluid you have. It can characterize the pleural fluid and then obviously provide guidance for your interventions, which can include thoracentesis, chest tube placement, tunnel pleural catheters, and even thoracoscopy. So those of you who have done thoracentesis, you know that this is what the pleural space should look like. You should always identify the diaphragm. If you cannot see the diaphragm, do not do a thoracentesis. This is the absolutely important landmark. You have the liver here on the right side. This is the lung. The pleural effusion usually is anechoic unless it has cellular debris. And then you have the chest wall, and it should be a hyperdynamic view. With each breath, the view should move unless the lung is fixed because of underlying disease. This is the study that I was referring to. This is not in malignant disease, but actually in paraneumonic effusion. But this is the study that shows that looking at the pleural fluid and characterizing it can actually help you determine prognosis and even what intervention is going to be helpful. So in a prospective study of about 163 patients with empyema, they identified 4 different patterns of pleural disease. You have the septated, and then the 3 different kinds of non-septated. This is simple. Then you have homogeneous, and then heterogeneous with little echoes. And so they followed these patients prospectively, and they found that septated patients actually required more aggressive treatment with chest tubes, fibrinolytic therapy, surgical intervention. They stayed in the hospital longer. So this is why for people who study pleural disease and deal with pleural disease, ultrasound is so important. Sometimes you put your probe on the pleural effusion. It's a huge effusion, but it's so septated that you know that this patient is going to require more than just antibiotics, more than just a chest tube or a thoracentesis. And I think we should familiarize ourselves with the pleural space by using ultrasound, even when the effusion is large. This is the study which makes me a little scared. It showed that even in experienced hands with large effusions, the rate of pneumothorax went significantly low with ultrasound. And so in 2 separate studies, it was 30% or so, which is fairly high for thoracentesis. Maybe it was just interns. So 30% to 0%, and about 18% to 3% with ultrasound. And even when people had a pneumothorax with chest ultrasound, very few of them required chest tubes. Now, these studies were done with somebody looking at the pleural fluid and going in with a needle. So it was a real-time ultrasound. But we don't do it that way. Usually, there used to be a time when you would bring the ultrasound tech and he would do an ultrasound, and you came in the morning and saw an X on the patient's back, and you had no idea in what position it was done. So that is the wrong way to do it. So the way we do ultrasound is patient's already in position, we do an ultrasound, and then we mark the spot, which is pretty close. So I think you can use that technique, and you will still be safe. All right. So in this study, the same study, they had experienced physicians, and they did their tap, found where they were going to go, and then when they went in, if they had, quote unquote, a dry tap, then an ultrasound probe was put on that spot, and they found that 60% of the time, those experienced physicians were actually below the diaphragm. Yeah. And in about 90% of those situations, they were able to find a good spot with ultrasound. So ultrasound was able to find a good spot if you used it right away, 26% time, and decrease the potentially dangerous needle insertion by 10%. So there are important organs under the diaphragm. So please use ultrasound to reduce your risk. Pleural manometry, this is something you will see probably at the VA. We're trying to bring it here. This is to determine pleural pressure. It's an incredibly controversial topic in pleural disease. So this is the new age pleural manometer, $45 a pop, but disposable, very easy to use. So you can hook it up to the thoracentesis catheter and measure pleural pressures in real time, and we do it at the VA in situations where we suspect a trapped lung. So this is a very classic figure that comes from work of many people about 20 years ago. So as you take pleural fluid out, the lung should expand, and as the lung expands, the pressures equalize. So in a hepatic hydrothorax, you have very little change in pleural pressures because the lung is able to expand. There's not much protein. In malignant effusions, the lung could be entrapped, meaning there's a fibrous layer on the lung, so it doesn't come up that much, so you start to create a vacuum in the pleural space. And if this process gets worse or is allowed to get prolonged, or if there was an infection, inflammation, then the lung can get permanently fixed, and that's called an entrapped lung, not an entrapped lung. And I did not come up with these terms. Or called an unexpandable lung, and we'll see it later. Patients can have some deep pain, and these are the patients who are at risk for re-expansion form edema. So in these patients, the pleural pressure will drop very fast, and you can use pleural manometry to determine it. What's the use of pleural manometry? Generally, they tell you not to take out 1.5 liters of fluid because it causes re-expansion form edema. If you're using pleural manometry and the pressures are staying close to the initial pressure, you can technically take out liters and liters and not subject the patient to repeat thoracentesis. So this is the benefit of pleural manometry. So in our patient that we discussed, we used an ultrasound. It was a simple pleural space. We took out about 2 liters of fluid, which was sent for cultures, chemistry, cytology, came back as lymphocyte predominant, exudate by Light's criteria, and the cultures were negative. This was her cytology. You have these lymphocytes for comparison, and then you have these large pleomorphic cells with high NC ratio. This is her thin prep. The same cells seem to be gathering around to form a little gland. Now, they ran a battery of immunohistochemical stains to determine what kind of malignancy she has. She's a smoker with a history of breast cancer. Is it breast cancer? Is it lung cancer? Is it some other cancer? So despite many different immunohistochemical stains, they could not determine what is the primary. So the diagnosis at this point was malignant pleural effusion due to adenocarcinoma of unknown primary, and immunohistochemical stains were inconclusive. So the question is, what do you do now? Do you repeat thoracentesis and send more fluid for cytology, check serum tumor markers, do medical thoracoscopy and get a pleural biopsy, refer to medical oncology, which is almost never a good idea, refer to thoracic surgery for VATS, an equally bad idea? And your time starts now. All right. C. So I think I have already biased you with the title of the talk. C is correct, and we will talk about why. This is a very historical figure in pleural disease. So the sensitivity of the 3 main techniques of determining the etiology of pleural disease. You have thoracoscopy on the right side. You have pleural fluid cytology and blind needle biopsy, which again is almost never done these days, especially in this country. So blind needle biopsy, about 44%. You can combine it with cytology. It takes you up to 74%. But obviously, thoracoscopy is so high that you can add anything to it, and it really doesn't change its sensitivity. So if you take all kinds of cancers, the pleural fluid cytology has about a 50% yield. If you take only adenocarcinoma, it goes up. So adenocarcinoma gives you a higher yield. Lymphomas give you a lower yield. A second tap generally adds to your yield by about 10% or so. So where do you add a medical thoracoscopy? Is it after the second tap or after the first tap? Is again an unsettled question. But if you have the ability and the expertise to do medical thoracoscopy, then that should be the next step. It's very safe and minimally invasive. How much fluid do you send? Again, this is a battle that we fight in different institutes. Should we send the whole bag, or should we send just only 50 cc's? At the VA, if you send the bag, they essentially throw it away. Over here, you send the whole bag, and they say, where's the next bag? So we don't know. But this study looked at the volume that is needed to maximize your pleural fluid cytology. And so with less than 10 cc's, sensitivity was about 25%. And you start to maximize it, meaning maximize, you start to get into the range where you're probably not going to go higher, around 40 to 50 cc's. So at least send about 50 cc's of fluid if you can for pleural fluid cytology. So she had medical thoracoscopy, and this is Dr. Jacobius, who actually used a cystoscope in the early 1900s to do medical thoracoscopy. This is when he was young. This is when he was old. And this is Dr. Jacobius doing medical thoracoscopy with a cystoscope, no hat, no gown, no gloves, no sterile drape. I'm almost sure he didn't do a timeout either. But anyway, we are indebted to Dr. Jacobius because he introduced an incredibly important intervention in pleural disease. And there's a book where he actually has hand-drawn what he saw, which shows how good his observation was, because this was not a time where you could actually take still photos and have had the opportunity to use fentanyl and midazolam and whatnot. So these patients oftentimes were completely awake. So, their observation was amazing. This is how it's done these days. This is how we do it here. And as of last week, we will be doing it at the VA as well. This is the flexi-rigid medical thoracoscope or pleuroscope, which looks like a small bronchoscope. Those of you who have seen a flexible bronchoscope, this is what it looks like, except that for the most part, it's rigid, and the distal 5 centimeters are flexible, so we can move around in the pleural space. And it's generally done in many parts of the world under general anesthesia on an inpatient basis, because they put a chest tube after they've done the thoracoscopy. Over here, we've been doing it under conscious sedation on an outpatient basis. Patients actually tolerate it better than bronchoscopy, and we use about a 1 to 1.5 centimeter incision, and we place a pleural drain afterwards. They go home, and it generally works out very well. So you would be asking, well, why are you doing this when we have thoracic surgery? That's a good question. Well, VATS is a much more extensive procedure, almost always done on an inpatient basis, requires general anesthesia, requires a single lung ventilation, is more invasive with higher mortality and morbidity, but obviously they can do a lot more. They can resect lungs and break down thick vascular adhesions, which we cannot. We can only deal with thin avascular adhesions, but the good thing is we can do this on an outpatient basis, minimal sedation, and the mortality and morbidity is very low. So in places where there is an active thoracic surgery program, sometimes bringing in medical thoracoscopy can be challenging. I know some of my colleagues who are still struggling with it, but over here we have been successful, and every time I'm able to steal a pleural procedure from the thoracic surgeon, this is how I feel. Yeah. So, all right, so our patient had medical thoracoscopy. She did very well. We found diffuse pleural studding, and we took multiple biopsies. So for those of you who haven't seen a pleura, this is what a normal pleura looks like. This is another patient with lung cancer that we did who had recurrent effusion, but his pleura was pretty benign. So normally the pleura is actually so transparent you can't even see it until you poke it, and then you know that there's this thin layer on the ribs. So you can see the underlying ribs, you can see the vessels. This is a close-up view. This is a normal pleura. This is what she looked like. So you can see a large metastatic deposit on the lung. You can see this thick studding of the pleura with vascularity. This is a hemorrhagic metastasis. This is looking at a right pleura on the right side and towards the bottom, which is usually where metastasis likes to go. So we took multiple biopsies. This is what the biopsies came back as. You can see these large cells, sheets of large cells scattered all over. This is a close-up of these cells. And this time, the immunohistochemical stains were definitive, and she was diagnosed with metastatic adenocarcinoma of breast primary, 8 years after mastectomy and just 5 months after her routine checkup that showed no evidence of disease. So now that you have diagnosed her with a metastatic breast cancer and malignant pleural disease, what do you do now? Do you put a chest tube, a small bore chest tube? Do you put an indwelling pleural catheter? Do you do thoracoscopy again and do pleurodesis? Or do you put a large bore chest tube and do pleurodesis? Or do you do VATS and pleurodesis? No, it was not. Good question. All right. Indwelling pleural catheter, good. So that would be the answer. Now, In our situation, because we do thoracoscopy on an outpatient basis, we put the pleural catheter as part of the procedure. But in many places, like I said, it's still done on an inpatient basis, so patients get a chest tube until they get a diagnosis, and the chest tube is taken out in 2 to 3 days, they go home, and then get a pleural catheter later on. But we have been able to do everything in one go. So let's talk briefly about the long-term management of pleural disease, which is what the challenge is. You chose pleural catheters, and that is generally the right answer in most cases. So when you have a malignant pleural effusion, you get two main options. You can either put some kind of a drain that doesn't prevent fluid from accumulating or coming into the pleural space, but you have a way to drain it. And so indwelling pleural catheters have become the standard of care here, and they are acceptable for expandable and unexpandable lung, meaning trapped lung. Then you have pleurodesis, which is the other option where you put any kind of sclerosing agent to fuse the two surfaces together. But this option is only there for a lung that actually expanded after you took the pleural fluid out. If you have an unexpandable lung where the two pleural surfaces are still staying away, and we'll see some pictures of it, then pleurodesis is not going to work. When it comes to pleural drainage, if the patient's prognosis is very poor, typically considered to be less than a month, then you can just do repeat thoracentesis. You don't have to subject them to a pleural catheter. But if they have a prognosis that's beyond 1 month, then placing an indwelling pleural catheter makes sense. Pleurodesis can be done the traditional way, where patients get a chest tube and then you pour this talc slurry, or it can be done video-assisted, either with a thoracoscope or VATS. So this is an unexpandable lung. You can sometimes see this kind of a chest X-ray after you do a thoracentesis, and the radiologist will almost always call it a pneumothorax, and it sends all kinds of shock waves throughout the hospital. But the one thing you need to know is whether the patient is symptomatic or not. And oftentimes the patients are completely asymptomatic, or they may just have a deep pain. And this is a situation where pleural manometry can help. If when you were doing thoracentesis, you check pleural pressures and the pleural pressures were negative, and now you have a chest X-ray like this, it's a trapped lung, and you don't need to panic. This is unfortunately one of the complications of long-standing pleural disease. When it comes to intervening in the pleural space, there are so many different options these days. You obviously have the thoracentesis. You have the pigtail catheter. You have small bore chest tubes of all sizes. You have the garden hoses, surgeons special. You have the medical thoracoscopy. You have indwelling pleural catheters, VATS, and open thoracotomy. So these days, the options are many, but things are moving more towards the smaller, less invasive, more comfortable, more cost-effective options, which is this. Pleural catheters have become so common that most of you answered the right question. I think about 10, 15 years ago, it probably still would have been pleurodesis or some other more invasive procedure. These are the two main kinds of pleural catheters. At the VA, you will see Aspira. Over here, you will see Pleurex. And obviously, the companies were very smart. So if somebody has an Aspira catheter, you cannot use the supplies for Pleurex, and the other way around. So if somebody comes in and you have an Aspira catheter in them, unfortunately, you'll have to get the supplies for Aspira. So these are a few studies. We'll go through them quickly. So we talked about pleural catheters being better as opposed to talc pleurodesis. This is a study from 2012. You have pleural catheter, about 59 patients, talc in about 50 patients. And over here, the length of stay for pleural catheters was 3 days, which is a little surprising because it really should be 0 days. But regardless, talc pleurodesis required more time. Patients have pain, fever. Often they have a chest tube, so they stay in the hospital longer after talc pleurodesis. What is important is that re-intervention was more common in talc, and we'll talk about it later on, that pleurodesis in about a third of the cases can actually fail down the road, typically about 180 days, and sometimes patients have to get pleurodesis again or eventually end up getting a pleural catheter again. What is more cost effective? So this is a study that looked at the various ways to deal with malignant effusion. You have repeat thoracentesis, tunnel pleural catheters, bedside pleurodesis with a chest tube and talc slurry, or thoracoscopic pleurodesis. So in patients who survive less than 3 months, repeat thoracentesis and tunnel pleural catheters were cost effective, but if they survived longer, then bedside pleurodesis actually climbed up because the supplies for pleural catheters are expensive, about $300 per bottle. So if the patients are surviving for many, many, many months, then that cost starts to go up. Just something to keep in mind, but this study, or at least studies like this, still have not tilted the practice towards pleurodesis. I think tunnel pleural catheters still continue to be physician's favorite and patient's favorite. This is another study from 2013, which again looked at talc poudrage, which is insufflation through a thoracoscope versus talc pleurodesis versus tunnel pleural catheters. And again, the length of stay was better in tunnel pleural catheters. This is an older study. This is the only prospective study that looked at chest tube with doxycycline pleurodesis versus pleural catheters. And again, the hospital length of stay was better. So I think the theme is that getting a pleural catheter is more comfortable for the patients. It's easier to manage for the patients. Patients stay in the hospital less, which comes out to be less cost, at least early on. And in about 46% of the patients, the pleural catheter itself can achieve pleurodesis just by the fibrogenic effects of the catheter. You may not even need to instill anything. So you can achieve both results eventually. This is what we alluded to in the beginning, the unexpandable or trapped lung. You will see this picture more in pneumonic effusions than in malignant effusions, but in malignant effusion you can have this situation where there is a thick peel on the lung, and even though the effusion has been taken out and there is a drain, the lung is not coming up. And this is a situation where pleurodesis is obviously not going to work, and the treatment of choice for these patients is actually a trapped lung. It's actually a pleural catheter, which supports the fact that the mechanism of dyspnea in pleural effusion is not just the fact that the lung is not working. Because even in these patients, you can have symptomatic improvement. And the main reason we think for dyspnea in pleural disease is the fact that their diaphragms are not working well, and there are neurogenic mechanisms as well. So in about 116 patients with trapped lung, when they received their pleural catheter, most of them felt satisfied in terms of their symptoms, ease of mobility, and ease of management. There were some adverse effects, but usually they are pretty mild. This is a large study looking at about 19 studies, and again, symptomatic improvement was about 95%, spontaneous pleurodesis about 45 days, and then there was a smattering of complications, but most of them were fairly small, simple, easy to manage, and did not require removal. The oncologists often worry about causing infections in patients who are immunocompromised, neutropenic, getting chemotherapy. There are multiple studies now looking at these patients who either had indwelling pleural catheter and started chemotherapy, or had pleural catheters placed while they were immunocompromised. And again, the risk of infection was about 5% to 10%. Mortality was still fairly low. So it's still a very safe intervention for patients who are immunocompromised. When and if they do get infected, the organisms are essentially the same that we know to reside on the skin, gram-positives, including Staph aureus, and gram-negatives. What is very important to determine in these situations is whether the infection is confined to that tunnel, or is it a pleural space infection. So if there's infection in the pleural space, which will require us to aspirate the fluid and send it for cultures, or the fluid itself can be purulent, then that is a much bigger problem to deal with and often requires removal of the catheter. But if the catheter tunnel is infected, most of the time you can treat it with antibiotics alone. Once the catheter is in, how often do you drain it? That's another controversial issue. This was the ASAP trial where they randomized patients to daily drainage versus every other drainage. Patients who had daily drainage were able to keep their pleura drier, obviously, and about 47% of them achieved autopleurodesis, as opposed to 24% with every other drainage. But overall, the symptoms were the same. So this is another study where they were trying to determine how fast should we pleurodese patients or how long the catheter should be in, because again, patients worry about infections, loss of electrolytes. So they randomized patients into two groups. One was the regular, usual, standardized way where you get the pleural catheter and then you wait till the pleura is dry and then you pour your talc slurry, versus the other group where the catheter was placed, effusion was drained, and then slurry was placed in, the catheter was clamped, and then about an hour later, the catheter was removed. Again, there was equal response in both of them, but obviously the drainage time was less in group one. Generally, our practice is that we start with every other day or every day drainage, and then we reassess in about 2 weeks, and we can decide when the catheter can be removed or when the drainage schedule should be changed. A few words about pleurodesis. You will probably see this less often, but still we see some patients who request pleurodesis or situations where pleurodesis is more appropriate. Of all the different things that have been tried for pleurodesis, talc has actually taken over as the most appropriate. Usually used about 2 to 5 grams. There are two ways of pouring talc. Either you can mix it in saline and pour it as a slurry through a chest tube, or you can use talc insufflation, which is just spraying in the pleura. This just goes to show how much work has been done in figuring out what is the best method and best agent for pleurodesis. You have all these comparisons. This is from the Cochrane Review, and obviously talc hydride has come out to be the winner. Talc is a magnesium silicate. It's naturally found in the earth, unfortunately in the same part of the earth where you can have asbestos. So for quite a while there was some concern that the talc that we were using was contaminated with asbestos, but that hasn't really turned out to be the case. Whether you use talc as a slurry or as an insufflation is still somewhat unsettled, but talc insufflation, which is just spraying talc into the pleural space through a video-assisted device, has come out to be more favorable. When you compare talc with bleomycin, obviously the recurrence of pleural effusion is higher in bleomycin as opposed to talc. There's always concern about causing ARDS. You will hear it and may even see a patient who developed ARDS after talc insufflation. Well, it turns out that the risk of ARDS is related to the size of the talc particle. The larger the talc particle, the safer it is. And it is assumed that the smaller talc particles can actually get into the capillaries and start a cytokine storm that leads to ARDS. So a talc particle that's more than 20 microns is safer. The best talc in the world in terms of size is from France. No surprises. Taiwan, Brazil, all in the higher talc particle. The U.S. talc particle size is pretty small. So President Donald Trump, if you're watching, the U.S. is losing the fight to France, China, and South America. I don't have a Twitter account, so if he replies, please let me know. So there was a study done in about 500 patients where they exclusively used this large particle, French talc, and there were no cases of ARDS. So I'm going to get in trouble for saying this, but when it comes to talc pleurodesis, do not stay local. Buy the more expensive European stuff. What determines the success with pleurodesis? The higher the tumor burden, the less the success. So move early, and obviously the pleural space has to be as dry as possible, otherwise your talc would get diluted. Do not use any anti-inflammatory agents such as steroids and NSAIDs because we are actually trying to create inflammation in the pleural space. What size chest tube should you use if you're doing a bedside pleurodesis? Small bore, large bore? I think this debate is now settled in pleural disease. The large bore chest tubes that the surgeons still like to put in have really gone out of favor. So small bore chest tubes work just as well in all situations, even thick empyemas, except if you have hemothoraces. Then a large bore chest tube makes sense. So this study looked at time to pleurodesis, tube duration, when the chest tube was taken out, total length of stay, and it was essentially the same with large bore and small bore chest tube. So what's the summary of all this battle? That generally pleural catheters are favored over pleurodesis, except if patients are going to be surviving more than 6 months, because then cost starts to come into play. Talc is the agent of choice, and it's better to use a video-assisted device and pour it with insufflation rather than with slurry. Symptom improvement is generally the same. So in terms of dyspnea, it's generally the same, but with pleurodesis, because there's about a third of the patients actually recur later on, so they can require repeat interventions. So late complications with pleurodesis is something that you have to keep in mind. So our patient got a pleural catheter. She did great. She went to the oncologist, started chemotherapy. She was on an everyday drainage cycle, and then about 4 weeks later, her nurse called back and said all of a sudden her pleural drainage has dropped off, and she's got only a few drops. And the patient herself is fine, no complaints. So the question is, what do you do? Do you bring her in for an urgent CT scan, or do you instill some intrapleural, intracatheter fibrinolytic therapy because the catheter is clogged, or give her a course of antibiotics because there's infection? Do you do a chest ultrasound, or do you remove the catheter? Chest ultrasound, good. So she had a chest ultrasound done, and her effusion was gone. So you got the diaphragm here, the effusion should have been here. You got the liver, so her effusion was gone, and she will be getting her catheter out in the near future. So this is a very common scenario, and oftentimes the first call we get after a catheter is put in and the effusion goes away is like, there's something wrong with the catheter, right? This is her CT scan. You see the catheter going in. There's very little pleural effusion. This is not uncommon. So the pleural catheter itself can cause autopleurodesis, or the chemotherapy kicks in and the effusion goes away. Sometimes you have a situation like this. This is another patient with breast cancer who had a pleural catheter placed in, did fine, and then her effusion, her drainage went down, and she started to become short of breath. So what has happened is that her effusion has become incredibly loculated, and as this loculation got filled up with pleural fluid, it has pushed the catheter away anteriorly, and so the catheter is now walled off. And so she required a repeat catheter in the large pocket and actually had intrapleural fibrinolytic therapy as well. This is another situation, patient with lung cancer who had a similar situation. Catheter was placed in, did well, and then the nurse called and says he's not draining at all. So you see over here, there is an effusion, and the catheter is sitting nice in the pleural fluid. And if this is the situation, then there is something wrong with the catheter. And so what you need to do is what they found out in this study. The GI doctors, I think there's still some places where they pour Coke or Pepsi or Sprite, whatever have you, through PEG tubes to declot PEG tubes. We don't have those options. So Pepsi, Coke, Dr. Pepper is equally unsafe in pleural disease. So 172 patients with clogged up catheters, they instilled about 2 to 4 milligrams of alteplase and then allowed to stay for about 2 hours. And there was 100% success. There were some episodes where they had to do it again, but overall it was very easily done, and patients tolerated it well. This is the thing that I worry about as someone who deals with pleural disease, and I put a pleural catheter in, and then they come back, and they're not draining. This is a complex multiloculated effusion, which can again happen because there's a huge tumor burden, there's high protein, you've got a foreign body sitting in the pleural space. So what has happened is that the pleural fluid has become incredibly loculated with trapped pleural fluid, and if you did thoracoscopy, you'll see this thick vascular adhesions. This is a very difficult situation to deal with. British Thoracic Society guidelines do recommend fibrinolytic therapy, but we have to keep in mind that most of the data on fibrinolytic therapy in pleural disease is in parenchymal effusions. The risk of hemothorax is slightly higher in malignant disease, but this is usually the option. We talked a little bit about prognosis in pleural disease. There are two studies that have looked at prognosis in pleural disease. Generally, the prognosis is poor, but can be objectified. So they came up with this score called the Lent score, which consists of LDH, the ECOG performance status, your neutrophil to lymphocyte ratio, and the tumor type. So based on this, they categorized patients into low risk, moderate, and they found a very good correlation with the Lent score and prognosis. So a higher score means a poorer prognosis. This is a study from Turkey where they looked at patients who survived less than 30 days versus more than 30 days. And the multivariate analysis showed that high-risk tumors such as lung, stomach, soft tissue, bladder, esophagus, low glucose value, and a poor performance status meant that the patients were more likely to die within 30 days of diagnosis. So I think most of you got the questions right, which means that all of us are on the same page when it comes to pleural disease. If you have someone who's suspected to have malignant pleural effusion, you do the thoracentesis. If it does not recur, you do not require any further intervention. If it does recur, and then you find that there was cancer in the cells, in the fluid, then you see if the patient is going to require long-term management. If you are still looking for diagnosis, and these days the term diagnosis of cancer is becoming more and more difficult, and it's an evolving concept. I guess Dr. Cloker is not satisfied when I say it's adenocarcinoma. He needs all his fancy numbers and his stains and whatnot, so sometimes you do have to do pleural biopsy. And then the very important question in terms of long-term management is whether the lung is expanded or not expanded. For most of the situations, even if it's expanded or not expanded, you're going to go with the pleural catheter. In some situations, you'll think about pleurodesis, but you have to make sure that it was an expandable lung. Both the surfaces were together. This is what I hope wasn't going to happen, because I don't want to remember the names of all these drugs that they keep coming up with. But this study in China actually used intrapleural chemotherapy. 72 patients with non-small cell lung cancer, they randomized them to group 1 and 2. Group 2 just got intrapleural cisplatin, and then group 1 got intrapleural cisplatin plus bevacizumab, and they found that the group 1 actually did better. And there was some correlation with VEGF levels. So this may be the newer age of malignant pleural disease. So I would like to summarize that we know that malignant pleural effusions generally mean high morbidity, high mortality. Remember chest ultrasound when doing thoracentesis, when following these patients, when looking for complications of pleural interventions. They are the treatment of choice. Patients who are expected to survive more than 6 months and have a good performance status can be considered for pleurodesis if the lung was expanded. And medical thoracoscopy, minimally invasive, easy to do. We do it on an outpatient basis. We can place the pleural catheter at the same time, do biopsies, even break down simple pleural adhesions. And it's something that's very easy to do. This is probably where things are heading, that pleural disease is now becoming its own little specialty within pulmonary medicine. In many parts of Europe, they have a special pleural service. And I hope that with the help of our fellows and our residents, we'll be able to start a pleural service, a rigorous pleural service here. A message to the residents: if you're not comfortable with ultrasound, you can call our fellows anytime. They're very proficient in chest ultrasound. and they will be happy to help you anytime. But do not do a blind thoracentesis in an academic center, I guess. All right, thank you very much. Yes. Mm-hmm. Um, I mean, I guess my simple answer is I don't see why we cannot and should not, but I don't think it has been looked at. Absolutely. Um, I guess in North America, it's out. In many parts of the world, because I guess tetracycline is probably still cheaper, it's still used. The risk of fever, chest pain, those kind of things that we worry about is a little bit higher with doxycycline and bleomycin. So talc has really become the agent of choice. Studies have also shown that talc actually works better than other agents. I mean, you can do anything. I mean, you can pour dirt in the pleural space, and it will cause pleurodesis. I mean, sometimes the surgeons can actually rub the pleural space. So pleurodesis is a pretty archaic procedure, but talc is probably the agent of choice because it works better if you use the fancy French talc. Thank you.
Consoles here from Manometry.